everyone.
Yeah, I should remember how to do this.
That's it. You have a couple of weeks off.
It's out of practice. Okay. I need to take the sound of this. So that's good. Okay. So we're on. Meeting is being live streamed. Okay, right. So very welcome everybody. We're very lucky to have Ryan today, Mr. Ryan Trickett, and also have Jill Arrowsmith, who's one of my consultant colleagues in Derby. As always, thanks to all the people who endorse us, BSSH, Plasta UK, and BOTA, who are the trainees in the UK, SECMA. Gracias, Eduardo, Papras, and Be First. A couple of reminders. FESH this year is in Italy, 10th to 13th of May. If you're going to go, get sorted, get registered, and find accommodation, because it's going to get more expensive as you go along. Unfortunately, the war in Ukraine is still going. If you can do something to help, there are lots of initiatives going on. Have a think about it. And welcome, Andriy, all the way from Kyiv, who's still there with us once again. Just another reminder, all the previous webinars, you can see them on YouTube. If you go to YouTube and you put pull with our videos, you will get them all there. And there are a few that I've re-edited because YouTube changed the way it presents things and they were not showing. So I've slightly edited them and put them back on. There is a course on anatomy, upper limb dissection in Bristol every year at the Vesalius Clinical Center, which is part of the Better School actually in Bristol. Great facilities, and this is run by Donald Samut. And I think there's still a couple of places free. So if you are interested, just email Donald at info@donaldsamut.com and come if you can, because it's a fantastic course. My only request, as always, please fill in the feedback questionnaire and I'll put you the link on the chat. And next week, we have Professor Dominic Furness, plastic surgeon from Oxford, who's going to tell us how to do high-quality research in hand surgery. And he's chosen the title of why we are failing to do it, really. We're not doing as well as we should be doing. So without further ado, Jill, the floor is yours. Thank you.
Thank you very much. So before I introduce tonight's speaker, I've remembered that I need to ask you all, please could you use the Q&A button for the questions you'd like to ask Mr. Trickett after the talk, because that's what I'll be monitoring in the session at the end of his talk. So I'd like to introduce Ryan Trickett to you. He's a consultant hand surgeon in Cardiff. He did his surgical training in Cardiff and then finished this off with some hand fellowships at Queen's Medical Centre in Nottingham and also with us in Derby. And it's a great pleasure to have him with us here tonight. Many of you will know him from the research committee of the BSSH, where he ran the James Lind Alliance process, and he's also been involved in health outcome measures. He's now the chair of the communications committee. He continues his research interest in trauma and patient-reported outcome measures and has numerous publications. He's also the convener of the Cardiff Cadaveric Advanced Hand and Wrist Fracture Fixation course. So he's going to talk to us tonight about mallet injuries and more. And the floor is yours, Ryan. Thank you very much.
Excellent. Thanks, Jill. Thanks, Carlos. Evening, everyone. And thanks to everyone from the Pulvertaft for inviting me along to this prestigious but virtual stage. So as Jill said, we're going to talk about mallets, baseballs and other DIP joint injuries. And in the best sense, I've got no conflicts, obviously. So disruption to the extensor mechanism at the level of the distal interphalangeal joint, and we often simply term these mallet finger as a problem that we all treat every week. We're going to talk through some of the controversies surrounding injuries at the DIP joint, but also some of the pertinent points surrounding the diagnosis and treatment of these injuries. And controversy in the DIP joint is probably the best place to start. This is Graham Stack's fairly famous paper from the late 60s, and he discussed his treatment of mallet finger and its underlying rationale back in 69. Although mallet finger itself had actually been described about 80 years prior to this. Variably and somewhat confusingly, also termed baseball finger or sometimes drop finger, the Bony mallet injury was described first in 1880, and soft tissue or tendinous mallet injuries described 7 years later. Dr. Alberto Uke gave an excellent webinar on the extensor apparatus anatomy back in July 2020, and if you've not seen that, have a look on YouTube. So I'm not going to labour the anatomy of the extensor mechanism a huge amount, but it's important to remember those essential bits of that, particularly how the distal joint works. So the common tendon of EDC splits into 3 steps over the back of the proximal phalanx in by here, and the central slit goes on to insert into the base of the middle phalanx, with the paired lateral slips joined by the interossei and the lumbrical radially to form the lateral bands, which go on to coalesce over the back of the middle phalanx, distal to the triangular ligament, and form the terminal extensor up here. And these books are from the Surgical Anatomy of the Handbook, which just shows really nice views of different things. So this is the inside structure of those tendons. And then the extensor inserts into the peristeum at the base of the distal phalanx, and it's got a relatively small area of insertion here. There's also fibers that insert into the DIP joint capsule itself, and what's called the nail halter, which is this combined structure of the proper phalangeal ligament, the phalangoglenoidal ligament, as well as the peristeum around the lateral aspects of the base of the distal phalanx. And it's this structure here that sort of hangs that germinal matrix tissue in. And importantly, cadaveric studies have shown that there is only a mean of 1.2 millimeters between the terminal aspect, the most distal aspect of the insertion of the extensor tendon here, and the proximal end of the germinal matrix. And we'll come to that later on. And then there's this fairly mysterious structure of potential importance, termed the oblique retinacular ligament of Landsmeer, often just shortened to the oblique retinacular ligament, or ORL. And I say potential importance because its function isn't really that well understood. And as far as hot debate in mallet finger circles goes, it's fairly hotly debated. This fibrous band runs from the base of the proximal phalanx down here and has some fibers that originate from the flexor sheath and courses obliquely past the PIP joint before merging with the fibers from the lateral bands and terminating on the dorsum of the DIP joint. And importantly, that axis takes it palmar to the central axis of rotation of the PIP joint and dorsal to the axis of rotation of the distal interphalangeal joint. And as such, theoretically, this ligament can both inhibit hyperextension at the proximal joint whilst exerting an extension effect at the distal joint. But the literature around the function of the ORL is somewhat confusing and often conflicting. Landsmeer thought that the ORL was important in dynamic tenodesis linking the proximal and the distal joints. Stack, in his paper in '69, thought that the ORL extended the DIP joint from 90 degrees of flexion to about 45 degrees of flexion, so halfway there, with the remainder achieved using the confluence of the lateral bands. And it's noted if you hold your proximal interphalangeal joint straight, you can only get about 45 degrees of flexion at the distal joint before it starts to feel quite uncomfortable. Whereas if you let the PIP bend, obviously you can get much more. And that kind of supports Stack's theory. That was disputed, though, by Harris and Schweitzer, who demonstrated that the terminal extensor tendon acted solely to extend the DIP joint on its own. But then conflictingly, complete sectioning of the lateral bands in a cadaveric model has been shown to only cause an extensor lag of 70 degrees in some papers, whereas sectioning the ORL in isolation does not seem to cause a significant lag. Other cadaveric workers demonstrate that the force required to flex the distal joint passively is greater when the ORL is intact, which would suggest that it's got at least some role in maybe not maintaining position, but resisting flexion. And this whole problem and discussion around what the ORL does is further compounded by the seemingly variable anatomical nature of it itself, and it's not identified in all cadaveric specimens. If you're interested in a paper about the ORL, there's a nice paper from Atkinson and Chung in 2014, with the references at the bottom there. So, armed with a bit of refreshed anatomical knowledge, how do we apply this clinically? And where do the mallets and baseballs fit in? So if we go back to Graham Stack's paper from 1969, the answers are kind of all there. We've not learned a huge amount in the last 50 or so years. He sought primarily in his paper to align the terminology used to describe the various presentations of injury to the extensor apparatus of the distal joint. And he described 4 main patterns of injury in his series of over 200 cases. A lot of these patients came from the Docklands in London, and as such, there was a slight overpopulation of young men having industrial injuries. So he actually described quite a large number of either sharp incised injuries to the distal joint or crush injuries to the nail bed, and they're kind of different. His main 2 injury patterns that he described was those that he termed mallet finger, and these had a clear history of forced flexion applied to the distal phalanx. And he assumed that that led to some partial shredding of the extensor apparatus, and he thought that this was just likely to be the central fibers of the terminal tendon, with those fibers coming from the ORL usually left intact. And this gave this sort of fairly classical appearance that we know of an extensor lag of about 45 degrees. There are other cases where there was a clear history of impact to the fingertip, and this was often from a poor attempt at catching a ball. And he termed these baseball finger. And these often presented with a triangular fracture fragment to the dorsal lip of the distal phalanx. And these are a compression impaction injury occurring in hyperextension rather than a flexion injury. So that distinction between these 2 patterns of mallet injuries was made in 1969. And unfortunately, these astute observations of that crucial difference between a soft tissue mallet and a so-called baseball finger, or what we maybe term a mallet fracture now, has not translated well into the modern literature. And many papers and resources, we can see here just a Google search for baseball finger, completely ignore the term baseball finger now, and I'm afraid my own paper is slightly guilty of that too. So if we pay careful attention to the exact mechanism of injury, we can predict a particular pathology, and this, I think, has to be the crucial first step in making the correct treatment decisions. Lower velocity injuries, for example, tucking in clothes or bed linen, with a better reported history of hyperflexion, are more likely to result in a tendinous or soft tissue mallet, or a flake avulsion injury, so a very tiny fragment of often comminuted bone. Higher velocity injuries, those described as an impact to fingertip, usually in catching sports, are hyperextension injuries and commonly cause that more significant dorsal lip fracture. And the differences between these 2 injury patterns were nicely demonstrated by a paper by Gray Giddings back in the European Journal last year. Before we decide on how we're going to treat our mallet injury, we must also think about the chronicity of the injury and the status of the proximal interphalangeal joint. An X-ray will help, and that should be our first line diagnosis. And it's really important to remember that whilst the generic hand X-ray may well show us that there is actually a fracture present, it won't tell us about the status of the DIP joint. So a true or perfect lateral of the finger is paramount to assess the exact nature of that bony injury, because we want to look at the congruence of the distal joint, and that allows us to classify the injury for people who think that's a worthwhile step. But more importantly, it probably informs our treatment. This is probably the most widely used classification by Weiss and Schneider, and it's widely cited in the literature, and it's used clinically as well. And excluding the physeal injuries, which are type 3s, it looks at the articular congruence as well as the size of fracture fragment, and it uses 1/3 and 2/3 as a cutoff for size. But the value of this as a classification is yet to be fully determined. And it's interesting to note that that classification doesn't really consider two things that I think are important: the presence of pre-existing degenerate change at the distal joint, which must influence our treatment decisions, and also whether we're talking about a true fracture fragment such as here, or whether we're just talking about what I would consider to be an avulsion injury, so a soft tissue mallet just with a tiny bit of bone on the end of the tendon. So how do we manage these injuries? And I've divided the treatments into those sort of common and less common presentations. I suspect there's little disagreement concerning the principles behind treatment of acute, closed, soft tissue or tendon mallet injuries. And these are almost universally successfully treated by splinting the DIP joint in extension. There is a little bit of discussion in the literature about the duration of splinting, and it does vary, but I think most people would advocate continuous splinting for between 6 and 8 weeks. Personally, I think anything shorter than 6 weeks risks early failure and ultimately stretching out of any healing tendon and lagging at the distal joint. So I think that's probably to be avoided. Some would recommend a prolonged period of night splinting on top of perhaps 6 or 8 weeks of full-time splinting. And whilst this isn't something that we usually practice in Cardiff, I don't think it causes any harm and may well prevent a re-injury to a sort of fledgling healed tendon. When I see patients with a soft tissue mallet, I take a few moments, rather than rushing them through and off to hand therapy, I take a few moments to warn them about a few things that I think are important that crop up in their recovery. They nearly always have a persistent dorsal prominence, and that can be quite sore and particularly painful, particularly in the first winter after the injury. I also explain the likelihood of some degree of persistent lag, and I go into details using knicker or pantelastic as an example, talking about plastic deformation and how that tendon just before it snapped irreversibly elongated and stretched. And it only takes a 0.5 millimeter of lengthening at this joint to give you about a 10-degree lag. So you don't need much plastic deformation to that snapped extensor mechanism to give you some persistent lag. And whilst this takes a few minutes at their first consultation, I find that it reduces the questions later on, although the hand therapists who actually look after these patients for us may well disagree with that. Good hand therapy colleagues are completely crucial in successfully managing these patients. And I'm very wary about patients who get discharged from the emergency department with a simple stack splint. I don't think they do well. The therapists have all the tips and tricks regarding how to wash the finger, how to change the splint tape, look after their splint, and basically live with a mallet splint day to day for 6 weeks. And these little things, they're not the icing on the cake for this. They're essential to maximize compliance. Because if you look at the literature tells you that compliance is key in underpinning successful treatment. If the splint isn't tolerated, if it's uncomfortable, if it rubs the skin, if it causes sweating or it's smelly, patients will take them off early or take them off intermittently in the wrong way. And as such, that treatment's going to fail. I'm very lucky we work with an excellent team of hand therapists who take quite a pragmatic approach to finding the best splint for each patient, and not particularly fixed to one method or another. And ultimately, it doesn't seem to matter in the literature. Here's a Cochrane review that showed there was no difference in patient outcomes dependent on splint design. Nick is one of our senior hand therapists in Cardiff, and although he's away tonight, he's going to quickly run through the fabrication of a thermoplastic splint for people who perhaps don't have easy access to hand therapy but can have access to thermoplastic materials, or for any hand therapist that would like to see how he makes his splint. And hopefully you can hear his sound. Please put in the chat if you can't hear his voice.
So in terms of patterns for this, I don't usually make a pattern for any of these splints. I just use a material and take a rough size. It's often just squares and rectangles, really. But some people like doing a pattern, and this is the way to do it. So we're splinting the long finger again. So I'm just drawing around there. You just make a note of where the DIP joint crease is and the PIP joint crease. And then once you've got the finger, so here's the DIP joint crease, here's the PIP joint crease. It's just two squares where the corners overlap, really. So you want a square, which is there, and it's just going to be slightly longer than the finger, and slightly wider, so that's just going to gutter up. And then this is going to be the join. Narrow. And then you want that wide enough so it's going to flap round circumferentially round the finger. So there we are, that's where the join is, or where the overlap is, and then you're going to make the equivalent overlap by joining it on afterwards. So you just simply find a nice space for the pattern, put that on the material, just draw around it, and then cut that out. Firstly, I'm just going to cut out some tubing net. This is 01 tubing net. This acts as a nice little barrier between the splint and the skin, and stops any sort of sweating, really, just makes it a bit more comfortable. Just move your hand back a little bit. So that sits on there. It's worth moulding the splint with this in place, because it just makes a difference in terms of the fit, even though it's only very thin. Okay, so if you just get the patient to lift their finger up, here's the two squares that we saw earlier. Putting one round there, and then sealing that one on there just below the DIP joint crease, and then sealing it at the end, and just helping this then to help lift the finger into some hyperextension. So we're just going to let this harden up now before we take it off. So this has been just being patient. And once it's gone off here now, you can just gently slide it off. Keep the patient's finger flat on the table, and then you can just trim off the excess here. And just make it a little bit shorter. So it's important that it doesn't go past the PIP joint, so you're able to freely flex that. So now we've finished the splint off, putting this back on the patient, and then just using some tape to secure it. What I've done, if you can turn your hand over please, I've just put a little slit in there, and then that exposes the skin so the tape can sit on there quite nicely and be secure.
So hopefully everyone, I'll take those off now, could hear Nick's speech there. There are a few things to modify sometimes on these splints. And at presentation and throughout recovery as well, it's crucial to have a look for the development of a swan neck at the proximal joint. And this can occur at any time. And again, this is one of the reasons why it's important to monitor these patients during their recovery. An easy modification to elongate the splint, and you can see here that Nick's just crossed the proximal joint, will control that swan necking. And by using a short piece of self-adhesive hook and loop fastening, you can permit that patient to intermittently unstrap that and allow some active flexion to prevent any PIP joint stiffness. And this is nearly always successful in treating the swan necks. Occasionally, there's some other slight alterations that are necessary for splinting these injuries. On the left here, you'll see Nick is using a dorsal-only thermoplastic splint. This isn't our routine technique. These are slightly less robust, but he uses them for ball-carrying sports people. And in Wales, that basically means rugby, although we've not got a rugby ball here. And it allows them to continue training. The dorsal location of the splint allows a less hindered sensory feedback when holding a ball, and players prefer these to train in. When they're not using the dorsal splint, they safely revert to a normal thermoplastic pattern. On the right side, you'll see that Nick's made a splint that goes dorsally, but allows some flexion here at the DIP joint. And we commonly use this for the treatment of mallet fractures, where there's some bony some articular incongruence. You can see the splints applied dorsally with a component passing palmally, and you can make these from a pure palmar splint as well. And that can help to improve the congruence of the joints. We get a check X-ray after applying one of these, which brings us nicely into closed bony injuries. And splinting is effective for congruent bony mallet injuries, regardless of whether they represent a true, what I would say, a Volscian type injury here, or perhaps something that's more of a hyperextension impact injury. Incongruence of the distal interphalangeal joints long been stated as an indication, an absolute indication for surgery. However, splinting can often, in a little bit of flexion, successfully restore congruence and avoid an operation. And this is in those injuries, as we discussed earlier, secondary to hyperextension. Even in the presence of persistent incongruence, splinting can still be successful, and we'll come on to that in a bit. Surgery can certainly restore that articular congruence, but the risks, regardless of the exact method of surgery used, I think are moderate, with infection or nail plate deformity reported in up to a third of patients in some series. Personally, I don't consider the dorsal fragment displacement to be of any real clinical importance when the joint's congruent. I don't see a huge morbidity coming back in patients associated with the displaced fragments beyond a slightly prominent dorsal bump, which even the soft tissue mallets get. Fixation of these small dorsal lip fractures is certainly possible and occasionally enjoyable, and the new lower profile hook plates are increasingly available on many hand plating systems. If we think back to that anatomy at the base of the germinal matrix, we've only got 1.2 millimeters of leeway there, and I think even this very small hook plate here is going to encroach on the base of the germinal matrix, and I think that probably always happens to some degree, so they always get nail deformity. My main concern with these is the overlying soft tissues, and infection at this joint can be devastating for function and appearance of the finger, and that for me shows that the risks far outweigh the benefits. So what do we do when the distal joint is incongruent and we don't want to fix it? Well, we can fix it, but the arguments are the same. So a lot of people will use the often slightly misquoted method described by Ishiguro of extension block wiring. And these diagrams are adapted from Ishiguro's paper and show the original technique, which stabilizes the fracture fragment with the joint in flexion, and then extending the distal phalanx up to reduce the fracture, and then passing an oblique transarticular wire from either the radial or the ulnar side. And Ishiguro stated that it was important to engage 1, 2, 3, 4 cortices with this wire, partly to maximize stability and partly to make it easy to remove should the wire snap. Transarticular wiring for me is simpler and also serves to restore a congruent joint, and you can see that here after a completely unsurprising failure of a Zimmer splint in this patient. Again, the dorsal displacement of that fragment isn't of huge concern, providing that the joint remains congruent, which it does after removal of that wire. It's a fairly stout wire used in this example, but that doesn't always leave much fracture surface area or even joint surface area left for function thereafter. The wire is usually left proud and remains in for 6 weeks. Healing time on these bony injuries is probably slightly quicker than the soft tissues, and the wire is removed and range of movement started immediately. So how do we decide what to do in these bony injuries? Is there a magic percentage of the articular surface that would indicate instability? Kim and Kim debunked the Weiss and Schneider misconception that a third was a threshold for subluxation, instead showing that 48% was involved with subluxation in their series. Gray Giddings suggested a more dynamic approach to testing stability, and he described 3 injury patterns on extension stress testing: gliding, pivoting, and tilting. Gliding means that the joint ultimately remains congruent and the distal phalangeal fragment glides up on extension, and you can see the pen here forcing the finger in extension. Pivoting is fairly obvious, showed here by the fact that the distal fragment pivots on the corner of the fracture, and this suggests instability. And tilting is a mixture of the two, where you get, I should say glide and tilt on the bottom there, tilting, which is a combination of gliding and pivoting. So you get pivoting at the fracture corner, but also some congruence of the joint. Gray defined instability that the main distal phalangeal fragment didn't remain congruent on this extension stress testing, and defined that as a millimeter of subluxation. But it's doubtful how easy it is to measure that on X-rays. But there was a strong association in his series between the gliding pattern on the left and ultimate congruence of the joint, and the pivoting pattern centrally and ultimately incongruence. But the clinical impact of these findings is yet to be fully appreciated. So, but are these joints, when they're incongruent, even important? And we published our series of 218 mallet fractures treated non-operatively in custom thermoplastic splints, usually for a period of 6 weeks, with that splint, as Nick shown in his videos there, either slightly flexed or in neutral. The ring and the little fingers were most commonly injured, and the joint was incongruent in 50 of our 218 fractures. And unsurprisingly, as we discussed earlier, an impact to the fingertip and presumed hyperextension was the most common mechanism in this group. We showed that ultimately, regardless of congruence or fracture classification, there was no difference in the pen, extensor lag, or pain scores between congruent and incongruent joints treated. There were some statistical differences in DIP joint extension and extensor lag, with both the size of the fracture fragment and the presence of pre-existing degenerate changes. These were minimal and largely secondary to outliers, and you can see the median measurements here are all 0 across all of those measures, showing that most patients did very well. And indeed, the DIP joint, with this in mind, has got remarkable potential to remodel. And I suggest that the long-term impact of reduced range of movement of this joint, as we know from our osteoarthritic patients, is negligible in most. There are some patients in whom I'd advocate treatment, and those patients with higher functional demands. Here's a professional cellist on the left and a high-level rock climber on the right, and more of a dislocated joint rather than a sublux joint may opt for surgery after a careful discussion around the risks and the benefits. I favour this simple transarticular wire. I think this keeps the pin-skin interface as far away from the zone of injury as possible, minimising the risk of deep, troublesome infection. I use a slightly smaller diameter wire than we saw in the X-rays earlier, and protect this with continuous use of a thermoplastic splint and careful hand therapy, education and monitoring. I don't worry about Ishiguro's perceived need for forecortex hold. I think you can see from these X-rays here, both these cases, that the wire shows a good intramedullary fit within that distal phalanx. And as such, I think you actually get quite a long working length of this, akin to an intramedullary nail in a long bone in the lower limbs. And this seems to keep things nice and stable. The title of the talk was Other Injuries, and other injuries do occur. We do occasionally see these pilon patterns to the distal joint. much the same as we see in the proximal joint, but these are thankfully much rarer, and I think they need to be essentially treated on their merits. Often a palm approach is easier. You don't have the issues of the narrow insertion of the extensor and the fragile germinal matrix, and you can easily approach the whole palmar side of the distal phalanx through a very safe midline internervous plane through the pulp. And patients don't get problems with scar sensitivity as long as you stay in the midline. But back to Mallets, because that's really what the topics, what the talk's all about. And we're going to talk about chronic injuries. I'm not sure how to define chronic injuries, and the literature varies from between 4 and 8 weeks. It's a somewhat moot point because I manage the chronic injuries as I would an acute injury, regardless of their time to presentation. I can't see any downside to a trial of splinting, regardless of that delay, although I do warn patients that their results are going to be suboptimal compared to treatment of an acute injury. That said, many do see some improvement in their extensor lag, and I'm not sure why this occurs. We know that the proliferative stage of tendon healing begins around day 2 and continues until around 1 or 2 months post-injury when remodeling begins. So presumably, some of the improvement that these patients seen is secondary either to a rebalancing of a partially lengthened extensor apparatus, or perhaps even the mischievous oblique retinacular ligament. But it's well known and reported back by Garberman and Paymer back in, I'm not quite sure when that was, but they, 1994, they showed no different in outcome for closed soft tissue mallet injuries treated non-operatively at a mean of 53 days post-injury. When a trial of non-surgical treatment fails and patients have a persistent but functionally limiting deformity, surgery might be indicated. But it's important to acknowledge that often these patients, their complaint will be one purely of cosmesis, and that needs to be carefully explored with the patient. For these injuries, there's a few options available. Elliot Serene reported his short series of 16 patients treated with tenodermodesis and K-wire stabilization with no bony injuries. So these were all soft tissue mallets. He maintained a wire for 6 weeks, followed by a further 6 weeks of night splinting. Didn't make any comment as to how long the sutures remained in situ for, but the other descriptions of this technique suggest leaving the sutures in situ for between 4 and 6 weeks. The mean extensor lag in his series improved from 50 to 9 degrees, with an associated improvement in the 5 patients who also had a minor swan neck at presentation. He didn't report any post-operative infections nor issues with the scar or nail, but didn't comment specifically on the nail plate cosmesis. And my slight concerns with this technique are the infection risk to both the germinal matrix as well as the joint. These sutures, these are 2.0 nylon sutures that he recommended using in his paper, are in continuity with the joint. And I think if they're left in for a prolonged period, that does risk infection there. This is a very attractive sounding operation, the spiral oblique retinacular ligament reconstruction, and it's performed by passing a free tendon graft around and along the finger, securing it at both ends. The original paper was using buttons, but other techniques are obviously now available. And the results of this in Thompson, Littler and Upton's original paper seem quite favourable, with correction of the swan neck and the mallet deformities. They do report a single patient who needed dynamic splinting to achieve full PIP joint extension, but they didn't report any long-term flexion contractures. And other papers, albeit very short case series, report equally favourable outcomes. Despite this, and certainly in my hands, I've got concerns regarding stiffness at the proximal joint, and I consider this to be a significant morbidity compared to some persistent lag at the distal joint. I usually prefer a Fowler's tenotomy, and this is in agreement with Nina Sue and Scott Wolfe, who looked at this in the American Journal back in 2013. And Bowers and Hurst originally used this technique, which was described way back in 1966 for treating chronic mallets with swan necking. And they demonstrated the importance of not sectioning the central slip, but lifting it up from its insertion by approaching through these transverse retinacular fibers here and preserving the whole extension of the extensor apparatus. And they reported universally good results, albeit in a short case series. In my experience, this procedures successful at improving the distal joint extension, and also treats swan necking at the proximal joint, allowing some rebalancing of the extensor apparatus without an obvious risk to stiffness at the joint. A cadaveric study compared a Fowler's tenotomy with a spiral oblique retinacular ligament reconstruction and noted no difference in the improvement of the mallet finger position, but a potential risk of some flexion deformity at the proximal joint, which I would consider preferable to a swan neck and certainly preferable to a stiff PIP joint. Chronic bony injuries are thankfully much less common, and they need fairly careful and balanced decision making. I think the benefits of attempted reduction in internal fixation here are far outweighed by the risks, and the likelihood of a good outcome is minimal. For me, I'd favour an arthrodesis here. Simple, cheap, well tolerated, and very predictable. Open injuries, similarly, are less common but can be very severe. And for simple lacerations, and we don't see a huge number of these, a tenodermadesis closure essentially converts that open injury to a closed injury. So I suture the skin and the tendon together using a normal non-absorbable suture, but remove those sutures at the usual time of between 10 and 12 days, but very carefully ensuring no flexion is permitted at the joint, and then ensuring careful splinting thereafter. So ultimately treating it as a closed injury. With adequate splinting, these usually do well. Where there's been significant soft tissue loss, there has to be a careful balance between the benefits of reconstruction and the impact of salvage surgery here. And I think absolutely in these cases, you should be wary about doing anything to jeopardize that important proximal joint and treat these patients on a very individualized basis. So how does my decision-making work? Well, firstly, the absolutes. Closed, soft tissue or congruent bony injuries are treated in a splint by my hand therapy colleagues. Open or complex other injuries may often require surgery, and I perform that tenodermadesis for simple lacerations and treat them as a closed injury. A more a la carte approach is needed for cases with soft tissue or bony loss or those complex base of distal phalangeal fractures, and I think you just need to decide that on the basis of what's in front of you. For closed bony injuries, I don't consider the size or displacement of that dorsal fragment at all in my decision making. And incongruent injuries are trialed in a splint, often in a degree of flexion, which may improve or restore their congruence. Where the joint remains incongruent and dependent on the patient's exact functional requirements, I have a very careful discussion with them, considering that level of function, considering any pre-existing arthritic change that might be present in the joint. And if we opted for a surgical approach to try and give them as good a possible joint, I'd certainly perform a transarticular wire. So in summary, how you can spend 45 minutes talking about mallet injuries, I'm not quite sure. But despite the huge range of splinting and surgical techniques, the literature doesn't completely support the use of one treatment over another. We know that conservative methods are proven to be safe and predictable in the majority of patients. For me, at least, the role of surgery is uncertain and the indications remain unclear. And surgery, I think, even in the most gifted hands, can be challenging with a high rate of complications or further surgery. And as such, my practice is based on achieving a predictable, functional result with the least risk of complications. And remember that the mechanism of injury will almost always give a clue to how to treat that patient. Thank you. And if I do that and I switch that back on, I might be able to hear people.
Thank you very much, Ryan. That was great. And I think you're wrong. I think spending 45 minutes talking about mallet injuries is perfect because it's something that we all deal with. And we often see things that have been neglected or managed inappropriately earlier, don't we? So I think it's entirely valid. So we've got a couple of questions up at the moment. So I'm going to start off with one of my questions. So you leave your when you do operate with the K-wire,
yeah,
and you leave that proud for 6 weeks.
Yeah.
So is that a bit long to leave a proud wire?
I don't think so. 6 weeks is kind of my limit for leaving KYs. We've got, and eventually we'll hopefully write up a big series of 600 KYs in the hand, and we looked at any diagnosis of infection. And I think my theory behind it is probably the closer your skin pin interface is to the traumatized tissue, the greater the likelihood is of mischief. And I think there's a fair bit of soft tissue at the end of the finger there. So you've got a nice soft tissue envelope that's not particularly mobile. It's not wobbling around. It doesn't get massively irritated by the pin being in situ. We have a weekly pin site clinic for these patients. They come back and it's all nurse led and they're kept an eye on, they're cleaned weekly. And we don't have a massive problem with wires that go in that way. On occasions where we've put wires closer to the injury, not necessarily for mallet injuries, and certainly around the PIP joint where the skin and that skin pin interface is much closer to your zone of injury, I think 6 weeks, yes, is absolutely too long. But I think we get away with it in the fingertip more often than not.
Yeah, I think that's one of the problems with Ishiguro's technique, isn't it, with the dorsal wire?
Absolutely, and I've seen a few of those that have come along in various guises and where they do get infected, and it's a disaster. It's a real disaster. If you get septic arthritis in the DIP joint, they never do very well. They're a difficult joint to wash out without a bony mallet injury and an incongruent joint and K-wires added into the mix. So they just don't seem to do well. So I think avoid that, for me, is the key thing of surgery around the distal joint, is avoiding infection.
Yeah. And then Rajiv Jose said, thank you very much for the talk. Great talk. And it's got a question for soft tissue mallets. So for tendinous mallets, how much hyperextension do you aim for in the splint?
I'll be honest, Nick and the therapy guys will do all of this for us. So we have a bit of a chat and then send them off to them, but they aim for as much as tolerable. So if you think that tendon undergoes some plastic deformation before it snaps, but it doesn't actually retract a huge amount, it's fairly well tethered. It's not like a flexor. It doesn't disappear off down the finger. You want to get that as short as possible. You don't see mallet injuries coming back with a loss of flexion. Even in our Bony series, where we've got good data on them, they don't lose flexion ultimately. They have a persistent lag. So I think as much hyperextension as you can cope with, and even if you get some bunching of that tendon, it's unlikely to heal short. And if it does, you can probably stretch it out with rehab thereafter.
Yeah, I don't think they ever heal short. I don't think...
I've never seen anyone complain of that after a mallet.
Yeah, our hand therapists certainly say that you always get flexion back.
Mm.
So we've got Pascal's asking, so if you've got a tendon-only mallet and you've done 8 weeks of splinting and they still have a 30-degree lag, would you carry on with splinting? Would you go a bit longer?
I don't know. There's certainly some patients in whom they tend to be slightly older, and we know that tendon healing is not so good in this scenario as you I don't say get older, but as you get slightly older, it becomes less good. And I'm not going to put a number on that, Jill.
Thank you.
But I think you've got to take it down to the patient. Some patients won't be bothered by a 30-degree extensor lag. They might have some osteoarthritic DIP joints anyway. It just won't be an issue for them. For those people in whom that is an issue, I don't see any benefit in carrying on with a bit of splinting. And you do see these improvements late. You see it with the chronically presenting ones. You do see a little bit just heal up. Sometimes that tendon takes a bit longer to fully tighten up, to fully heal. The truth of the matter is we don't really know what's going on the inside because we can't see it and we can't very accurately image it.
Yeah.
So I think there's little downside to splinting. Like we said, you don't see a stiff DIP joint from a mallet splint.
Yeah.
So I'd give it a go.
Yeah, absolutely. So Nick's asked about there's Carlos's light's gone. Nick's asked, he did warn us about a neglected open mallet. So if someone presented at like a month down the line and the skin heals, but they got a persisting mallet, where would you go?
So the skin's healed,
Skin's
Um,
healed. So we don't have an infection.
I think again, you've got nothing to lose by giving them a trial of non-operative management. You've got to warn the patient that it's a bit of a pain for 6 weeks, much like Carlos's lights going on and off in the background. Warn the patient it's going to be a bit of a pain for 8 weeks. It's going to limit them a little bit functionally, and it might not work. But when the options are a Fowler's or a tenodermadesis, or an SROL, actually a trial of splinting for a short period of time is probably the lesser of all those evils. And if they get a little bit back and they're happy with their 20-degree persistent lag, then I think that's a win for everyone. I think if that doesn't work, you just ignore the fact that it was open and treat it as a chronic soft tissue mallet presentation. And for me, I think that's a Fowler's. You don't very often see very, very flexed ones. And I think in those, they're the ones that might not do so well with the Fowler's. I think a Fowler's permits some rebalancing of the extensor apparatus. So if you've got a 70-degree lag at the distal joint, a Fowler's will reduce some of that by giving you some at the PIP joint. So you swap 70 at DIP for maybe 30 at PIP and 40 at DIP. And I'm not sure it does anything more clever than that. So in those patients, I might be swayed to go towards something like a tenodermadesis, and I would absolutely prefer that over an SORL, just because I don't want to jeopardize that proximal joint.
Yeah. And we've got a couple, thank you very much. We've got a couple of questions about bony mallets now. If it's a neglected fracture subluxation, would you consider wiring that? Do you think that the gap between the fragment and the main bit of the distal phalanx matters? Would that have filled up with stuff?
Yeah, I don't think the displacement of the dorsal fragment matters unless they're chronic, in which case it fills up with stuff very quickly, be that hematoma and then callus later on that you might not see on x-rays for months and months and months. And try as you might, unless you open that up and take it down, you're not going to restore that congruence. The collaterals on the distal joint are so short and so stout and so tight anyway, you're not going to restore that congruence without probably releasing them. And all of a sudden you've done a very big approach to sort of 2/3 of the circumference of that joint in order to restore some congruence and probably give them a joint that's either going to have recurrent incongruence, slightly cynically, or be painful and degenerate anyway. So for those people, I think just do something simple that works and is well tolerated and fuse the joint. And if that's in a bit of flexion because they need that functionally, then do it with a Lister loop. If they're happy with a straight DIP joint, then you can just debride the joint through the back and put a cannulated screw down. And it's predictable and it works. And I think it just gives people one operation to fix them.
Yeah. And we've got a question again about the dorsal blocking wire fixation of bony mallets. And what were your opinion and advice regarding that?
For me, I think that operation is just fraught with risk of infection. And Ishiguro's paper didn't report a massive infection risk. And maybe that's because they've got different tissues, or I don't know. But certainly in my patient cohort, with their slight unreliability turning up and that very narrow distance between the skin pin interface and your traumatized area, for me, that risk of infection is just too great. And it's an operation I have performed, but try and do everything I can not to do again for those reasons.
Yeah, I think in Derby hands, I think we'd certainly avoid that as well, if at all possible. And I think we'll finish with Mr. Oni's question, which is a 10-degree extensor lag of functional importance?
Almost certainly not.
Yeah, I think so too.
I think there's very few people who would find 10 degrees of extensor lag functionally important. The cellist who had the transarticular wire thought that she would. So that one of I think the X-ray on the left was a professional cellist who played for the Welsh National Opera, and she thought that would be an issue. It was on her, I'm not quite sure it's called a fret in a cello, but it was on the that hand, not the bow hand.
Yeah.
She felt that it would be important for her, which is why we wired it.
It's
I have spent today 15 minutes convincing a professional tennis player exactly that a 10-degree light is not going to be a problem, and it doesn't need an operation because of that. With his physio there and all the X-rays and everything, you know, some people get very fixated on this, so it's quite a long conversation, really. No, but that was fantastic, Ryan. Thank you very much for all your thoughts on this common problem that sometimes can become quite troublesome if not managed well. But it is something that we all see every week, and sometimes that is not managed very well. So that was excellent. Please, guys, fill in the feedback questionnaire, and I've put the link several times on the chat. Next week, Dominic Furness will be talking about how to do high-quality research in hand surgery. And actually, the week after, we're going to go somewhere very near to this. It's going to be about the nail and the nail apparatus and problems with it, which are little tricky problems, actually. And we have, I think, the guy who is the world expert, Christian Dumontier, originally from Paris. So that will link with these and problems near the fingertip. So thank you very much for that. Join us next week. Thanks to Jill for chairing the first webinar of this year. It's lovely to have Ryan there. And thanks to all of you for joining us on this Monday evening. Take care and have a good evening. Thanks a lot, guys.
Thanks all. Cheerio.
Thank you. Well done, Ryan. That was excellent. Well done, Thank you.
Cheers, Joe. See you, Carlos.
See you.
Bye.
Thanks for this.